Thank you, Council Member Kitchian. The Chair will now recognize members for 5 minutes for questions, and we'll begin by recognizing the gentlewoman from American Samoa, Ms. Radewagen, for 5 minutes. Ms. Radewagen.
Thank you, Mr. Chairman. Talofa Lapa. I want to thank the witnesses for being here today. Chief Hoskin, many smaller or mid-sized tribes look to Cherokee Nation for technical assistance and guidance. Based on that experience, what reforms would most help tribes with limited administrative capacity succeed under ISDEA?
Thank you, Congresswoman. I appreciate the question because I'm recalling the days of Chief Mankiller. Although the Cherokee Nation was a large tribe then, we needed technical assistance. All of her successors, myself included, needed technical assistance. A small tribe with a limited capacity just in terms of people power certainly needs that. So a structured IHS technical assistance program delivered in partnership with experienced self-governance tribes, which Cherokee Nation is, and I have to say my friend Jay Spaan and his organization can be instrumental to that and is instrumental to that, would be important for smaller tribes. Streamlining redesign approvals and compact amendments can reduce administrative barriers. Those tend to disproportionately affect small tribes. And of course, advanced appropriation and mandatory funding is good for all of us, but you can imagine having that hedge against uncertainty is much more important if you're a smaller tribe that has less ability than the Cherokee Nation does to look at our own resources to get through the storms of periodic funding lapses. Training, of course, is important in areas like billing, workforce development, facility planning. Those are things that took Cherokee Nation a great deal of time to develop our own expertise, and we had, of course, more people to do it with. So those are some areas that I think small tribes could benefit from. Thank you.
Council Member Kitchian, what do you need to see from IHS for this realignment to genuinely support more effective 638 implementation? And are there aspects of the current area structure that you believe must be changed to improve responsiveness?
Thank you for the question. Yes, I think that the capacity building is essential in each area, and it's been said across the panel that there are inconsistent expertise in some of the areas. And when you don't have the capacity to help and nurture a young self-governance tribe like the Winnebago tribe, we need that technical support, and we need the buy-in from the area and from headquarters down to the area that the support is there for the tribe to be successful.
So, Council Member Kitchian, if IHS could fix one thing tomorrow that would have the widest impact across Indian country, what do you think it would be?
It would be to streamline processes, expand 638, and tribes have been able to do much more with limited resources, and it would just be taking what the lessons we've learned and expanding 638.
Chairman Abrahamson, your testimony discusses the Spokane tribe's interest in assuming control of the Wellpinit service unit. What are the primary reasons the tribe believes that taking over Wellpinit under 638 authority improves care for your citizens? And what outcomes do you hope tribal management will achieve that the current federal structure has not?
Thank you, Congresswoman. That's a great question, because that's what, as I've traveled across the nation when I was the Direct Service Tribe chair, and as we visited a lot of these other facilities, and in the Northwest, we have some of the most innovative health systems out there that the tribes that have assumed their operations furthered health care for their people. And along with that there, we can be able to offer more with the federal government has restrictions on what they're able to pay their providers, and they have locums that come in a lot of times there too. We can provide providers that may stay there for a long time, offer more things that anybody would like to have as a doctor that's going to be there and continued care for our people, and be able to expand services for podiatry care, different functions of dentistry that can help health out for our people, for both the young and the older, to be able to even offer more preventiveness there too, so our people can live longer. As you heard earlier there too, that our people live less than what they should.
Thank you, Mr. Chairman. Yield back.
The gentleman yields. At this time, the chair recognizes the gentleman from the state of Washington, Ms. Randall, for 5 minutes. Ms. Randall.
Thank you, Mr. Chair. Mr. Spaan, as we discussed in the prior panel and you alluded to in your remarks, IHS is considering large organizational realignment where more functions and staff will be centralized at headquarters. Tribes across the country are worried that this realignment will further delay services and response times as positions like area lead negotiators are moved farther from the tribes that they serve and are encouraged to maintain strong relationships with. It's my understanding that IHS notified tribes of the realignment just last week on December 5th with 1 week to go before consultation. Yet IHS's tribal consultation policy states generally every effort will be made to provide at least 30 days notice prior to a scheduled consultation. Mr. Spaan, what are the consequences for tribal health care of improper consultation for large agency realignment like the one IHS has proposed?
Thank you for that question. With this consultation, it has been there's been a number of moving parts. So IHS did initially schedule a consultation much further in advance, and that was for a limited number of locations and sites. When that Dear Tribal leader came out announcing it, it was more of a, here's the locations that we're going to have it, here's the date, with very minimal information shared. It was December 5th before IHS provided any meaningful information to tribes to prepare for those consultations, and then they added additional dates as well at that time. So our concern was that in that initial letter, in that initial preparing time, it was basically, we're going to have a consultation, but tribes didn't have anything to review or evaluate to comment on. And so the short time frame, being able to look at this high-level executive summary and understand it, and then consider what impacts it's going to have, really hinders tribes' abilities to provide meaningful input. 638 implementation is tribally driven. It's tribally driven by law, by Congress. ISDEA intended for it to be a tribally driven approach that is not a one-size-fits-all. This is where tribes have the opportunity to decide what works best for them. And so having them as part of any realignment is critical, specifically now that nearly every tribe is participating in ISDEA.
Absolutely. Thank you. I think it's always important for us to remember that tribal consultation isn't a box to check in the process. It is the work of determining how we move forward in a way that honors sovereignty and our treaty and trust responsibilities. I also understand that IHS has proposed centralizing the area lead negotiators under newly created Office of Agency Negotiations rather than under the IHS director. And as mentioned previously, the lead negotiators are being in an area office allows them to have strong working relationships with the tribes that they serve. Proximity, the ability to connect in person, face to face, as Ranking Member Ledger Fernandez shared earlier. And I worry that the centralization at headquarters will reduce timely communication. And we have heard that, it may not happen exactly as we think it might happen, but I want us to be clear-eyed about what could happen if that centralization looks like it might. Area lead negotiators also have delegated authority to act on behalf of the IHS director, but I'm concerned that this proposal to create an Office of Agency Negotiations will shortchange tribes in that regard. Can you talk to us, Mr. Spaan, a little bit about the negotiation process and what the consequences are when those negotiations are not properly carried out for tribes to get the health care to their members that they need?
Yes, thank you for the question. And tribal negotiations is, again, a tribally driven process where tribes are deciding the terms and how they want to move forward in negotiating with the agency and redefining that relationship. What's worked really well in some areas is having that local team that knows the community, that knows the tribes, that has a history, and the tribes have built up those relationships over time. It also ensures that any of those decision-making activities that impact the tribe and the patients that are being served are being made closest to where they are located, that these are local individuals that know the communities, know the areas. So we do have a great concern about centralizing it, even if it doesn't mean moving people to D.C., that if you have this centralized process where you're pulling an ALN from Alaska to work with the tribe in Alaska, and then, in Oklahoma, and you're pulling general counsel from a different area, that you start weakening that relationship, and it becomes very transactional based versus relationship based, whereas the local people know what the community needs, and they're invested in making sure the health care for that community.
Thank you so much for your testimony and answers, and Mr. Chair, I yield back.
The gentleman yields. At this time, the chair recognizes the gentleman from Utah, Mr. Kennedy, for 5 minutes. Mr. Kennedy.
Thank you, Mr. Chair, for convening this, and thanks to the witnesses for being here, and I'm grateful for your testimony. Today's subcommittee meets to support a clear and necessary goal, and that's to modernize the Indian health services. And as a physician, I know how important it is that we have timely action and reliable systems to deliver the quality of care for our Native American populations. Too often, IHS is held back, though, by outdated processes, slow contracting, and persistent staffing gaps that delay the services tribal communities depend on and deserve. We've heard testimony from Councilwoman Kitchian on the initial life-threatening deficiencies of their IHS facility. Let me be clear, no hospital or health facility in the United States should have their services or lack thereof described as life-threatening. As such, while we should acknowledge the great lengths IHS has progressed in their quality of service and encourage its continuance, we must maintain this trajectory through careful congressional oversight. So I'll start with Chief Hoskin. Thank you for your willingness to be here and answer the questions, but the Cherokee Nation runs one of the largest tribal health systems in the country. With that scale, predictability is essential. So how do inconsistencies among IHS area offices affect long-term planning for a tribal system of the Cherokee Nation's size?
Thank you, Congressman. It is critical that we have consistency among agency offices, and it's critical that agency offices, first of all, exist, because the relationship we have close to people that are close to on-the-ground activities is indispensable. But they have to be empowered, and they cannot be undercut, and we've actually seen that in the Cherokee Nation's experience, where decisions by area office leadership has been undercut, in fact, by headquarters. And so it's important, though, to have that direct line of communication. Quite simply, area office folks know the tribal lands. They know our systems. They sort of have grown up with us, and that's really important because they know what's going on. And oftentimes, and then again, this isn't directed to any particular administration, oftentimes headquarters is a bit detached from what's really going on the ground, and there's a bit of re-education that has to happen. But I've heard about inconsistencies between offices, and we've had a really great experience with the Oklahoma City area office, and I would want that experience across the country, and standardization would be important.
How do you coordinate, though, with your local office? What's the best way to make sure that that happens?
Well, I think frequent interaction. I mean, there's no substitute for in-person interaction. In Oklahoma, we have, of the 5 large tribes, the Intertribal Council, and the area office representative invariably shows up not only to speak to us, but is there to talk with us. And you can't replace that with memoranda. You can't replace that even with virtual meetings with headquarter folks, even though there's very wonderful folks that work in headquarters. Having people that you're familiar with show up is important, and it can't be substituted with other means.
Thank you for that response. Ms. Kitchian, you've emphasized that tribes often face very different experiences depending on which IHS area office they work with. How has the area-level variation affected the Winnebago tribe as you've implemented and expanded your 638 authority?
Thank you for the question. The Winnebago tribe was the first tribe to assume a hospital in the Great Plains area. Only one other tribe had assumed management of a clinic, so my area lacked capacity, and I can, quite frankly, the willingness to not only triage a broken hospital, but also walk with the Winnebago tribe as we took over that hospital. And so this whole process has been challenging, and the Winnebago tribe advocated for special appropriation for hospitals that find themselves in jeopardy. And even through that path, we had to, after we advocated for that appropriation, we had to work with IHS to receive a portion of that appropriation. And so it's really the onus is on the tribe when you do not have the capacity or the willingness in your area to support the self-governance tribes. And so as we step into this modernization, I think some of the areas need more attention than others. And I think that there should be a priority list from either the tribe's experience or from some type of assessment. And having these metrics that were mentioned earlier, those are a wonderful start.
Excellent response. Thank you very much to the witnesses yet again. And Mr. Chair, thanks. This is an important hearing, and we stand ready to help wherever we can to make sure that these services are delivered effectively. And with that, I yield back.
Agree completely with that sentiment. Representative Kennedy, the gentleman yields back. At this time, the chair would like to recognize himself for 5 minutes of questions. Councilmember Kitchian, I loved what you had to say about uniform performance metrics, a 638 implementation manual. It's not clear to me why the BIA has one and IHS does not. Strengthening accountability and accompanying capacity improvements also with accountability. If a tribe was considering moving from direct service to 638, what's one piece of advice you'd offer them?
Thank you for the question. I would offer the tribe to educate themselves as well as their tribal members and on what 638 is, and that it's actually an exercise of sovereignty rather than a diminishment of sovereignty. And we are not letting the federal government off the hook per se for our treaty rights, but rather this is a mechanism to deliver quality and better health care services at the local level with local control and the care that only the relatives can provide.
Thank you very much. Chief Hoskin, it's great to see you again. You mentioned in your testimony healthcare is better when it's managed within the tribe and behavioral health issues as well. I think you mentioned that. Can you give us some specific examples of how this works and how through the 638 contracting or compacting you've seen improvements in healthcare delivery compared to what would happen in a direct situation?
Absolutely. Chairman, thank you, and it is good to see you again. The integration of behavioral health into our health system has probably been one of the best things that's happened in our health system. We're not in an era in which patients come in and then they're on their own to seek those behavioral health services or there's some disconnect. It is all in one system. So that is something Cherokee Nation decided to do because we put the patient at the center. And so if I were to come in and for some other ailment but need behavioral health services, it is really a holistic approach, and in some cases maybe a hand-holding approach to get someone to that service. One of the things that we're very concerned about the Cherokee Nation is making sure some of our population that may live in the shadows, particularly on behavioral health, stay in the shadows, and what can we do? So because we control our health system under 638, our health program working with our language program to make sure we're reaching some of these fluent speakers, Cherokee speakers, of which are on average over the age of 70. Many are living economically marginally. Many are living remote locations. And some of them aren't getting the health care they need. It is opening up things like a peer recovery program for fluent speakers with health program working with our language programs. It turns out good health care, adequate health care, excellent health care is not just inherently good. It turns out to be a great program for language preservation and revitalization. Getting those two departments to work together probably wasn't something decades ago IHS was even equipped to understand or execute on, but the Cherokee Nation is. Why? Because 638 has put all of that in our control. There's many other examples, but that fluent speaker peer recovery program is probably the most powerful one I've seen lately.
That's a very interesting example. That is truly comprehensive, integrated care there. And I assume it's led to better healthcare utilization, more efficient use of healthcare dollars. Is that fair to say compared to what it would be in a different context?
Absolutely, it's fair to say. I mean, just this week we had an issue where a patient needed some medical equipment, and they're, again, in our fluent speaker population. That turned into making sure that person, maybe for the first time in a long time, got primary health care. That only happens when we're over our healthcare system and we're able to bring in multidisciplinary approaches, multi-department approaches within the Cherokee Nation, only because of 638.
Great. Thank you, Chief Hoskin. Chairman Abrahamson, are there any support mechanisms that IHS could provide upfront, technical assistance, staff detail, planning funds that would accelerate tribal readiness?
Yes, thank you. And yes, there is. We got a couple of the grants there, but I think more support out front would definitely help the tribe as they got ready to transition over with getting the proper staff and proper consultants, and actually even being able to visit the best practice on some of these tribes that have gone through that and stuff, so you don't end up with, as we did after we assumed it with the system of RPMS there, of not talking. I was actually back here in D.C., and I might have been testifying or something there, but I was getting phone calls, and people couldn't get their pharmacies there, and they said, well, how are we going to do this? So they had to go back to old thing of trying to write it down, and they'd have to try to bring it to these places to get it there and stuff, and it was very difficult there, and being able to get referrals out.
Thank you very much, Chairman Abrahamson. And I see my time has also expired. At this time, I would like to recognize the gentlewoman from the state of Oregon, Ms. Hoyle, for 5 minutes. Ms. Hoyle.
Thank you very much, Mr. Chair, and I want to thank the panel for traveling to be with us here today. Each of you spoke about the importance of 638 contracting, and of course, I hear from my tribes all the time about the importance of this program. And it's a great tool, but it's only as effective as the resources available for tribes to carry it out. I mean, it's the basic, no money, no mission, right? Mr. Hoskin, in your testimony, you mentioned the importance of predictable and stable funding for the Indian Health Service, and Congress previously provided IHS with advance appropriations for fiscal years 24 through 26, which I strongly support, but the authority will expire soon. Could you elaborate on, why and how this funding stability has been important, especially during the recent government shutdown, and what's at risk if we don't re-up this funding?
Thank you, Congresswoman. Yes, advance appropriations is critical. We just experienced the longest federal government shutdown in the history of this country. Timing is everything. Had that happened in 1975 when I was born in the Claremore Indian Hospital, I'm not sure what my mother would have done. Had that happened when I was younger and my grandfather was going to Claremore Indian Hospital, or Cherokee Nation's health system was small and had great ambitions, I don't know what they would have done. But it would have been some lapse in service. It would have been someone not getting health care. And so advanced appropriations was perfectly timed. I mean, the Congress didn't know we would experience the longest shutdown in the history of the country. But because that was in place, I could be in a room with tribal leaders in which we were talking with some glee about the fact that our tribal nations were balanced budget tribes continuing in our operations, and our citizens weren't fearful of a lapse in funding. Now, Cherokee Nation's size has been a hedge against ups and downs of federal funding and even continuing resolutions and funding lapses, but I worry in particular about some of the smaller tribes out there. But even Cherokee Nation can't weather every storm. Advanced appropriation is a minimum. Mandatory appropriation should be the goal.
Perfect. Thank you so much. And I agree, that IHS funding shouldn't be subject to budget instability in Congress, and I'm confident we can work in a bipartisan way to make that happen. Mr. Spaan, as you know, the Supreme Court ruled in 2024 that IHS must pay the contract support costs that tribes incur, but I've heard from many tribes in my district that these costs are taking up a large share of the annual appropriations for IHS. So in your testimony, you expressed support for providing mandatory appropriations to cover these contract support costs. Could you share more about this issue and how mandatory appropriations would help tribes provide more affordable health care to its citizens?
Sure. Thank you so much for the question. As you know, the contract support costs are a critical piece of the success of ISDEA. Tribes, whenever they take over these federal programs and these federal responsibilities to provide services, there is an administrative piece that comes along with it. And this CSC funding is what helps to ensure that the programs get fully funded and that the administration doesn't cut into those program costs. The courts have found that CSC is an obligation of the United States, and there's a responsibility to do so. we definitely fully support making CSC mandatory so that there isn't this risk within IHS of cutting into program funds. Nobody wants to see programs suffer because of CSC, but CSC is as much critical as those program funds are.
Thank you so much, and I yield back.
The gentlewoman yields. At this time, I wanted to just take a quick moment to say that I'm pleased to welcome another Grijalva to the House Committee on Natural Resources, specifically the Subcommittee on Indian and Insular Affairs. This is Representative Grijalva. You'll see as we strive to be a serious subcommittee focused on bipartisan principles that strengthen tribal sovereignty, that respect the government-to-government relationship that we have with our tribal partners, and that promotes self-determination in Indian country. And then we also work with our insular partners on critical issues of economic and national security. And so I just want to say welcome, Representative Grijalva, to the Subcommittee on Indian and Insular Affairs. It's great to have you here. And with that, the chair now recognizes the gentlewoman from the state of Arizona, Ms. Grijalva, for 5 minutes. Ms. Grijalva.
Thank you, Mr. Chairman. I appreciate that. And thank you to all the witnesses for being here today. As we've heard, the United States has a trust responsibility and trust obligation to uphold the treaty for health care to the American Indians and Alaska Natives. This is accomplished by consulting with tribes and then actively advocating for policy, legislative, budgetary planning, and for appropriate health care. I believe it is clear that often our federal government falls short, and what we should do is be clear, comprehensive, and fair consultation process. I think we all can appreciate the desire to increase efficiency. Unfortunately, under this administration, we have namely seen confusion, chaos, and backlogs created in the name of efficiency. Tribes in Arizona have demonstrated their ability to effectively deliver healthcare services, often doing more with less, while strengthening local economies and providing culturally appropriate care. I do agree that there are areas for improvement. For instance, currently only the Indian Health Services, IHS, is required to confer with urban Indian organizations on healthcare policies and initiatives for American Indians and Alaska Natives living in urban areas. This despite the fact that the vast majority of American Indians and Alaska Natives, roughly 70%, live and seek health care in urban areas outside of IHS jurisdictions. However, I am concerned that when this administration talks about modernizing the 638 contract program, the end result will be staffing for critical job functions. So, Mr. Spaan, you note in your testimony, tribal administration of health programs can lead to better results, stronger accountability, and more effective use of federal resources. Part of this realignment plan is to nationalize the ISDEAA negotiations, which you note has potential downfalls. Can you talk about the end result of a failure to have a full and fair consultation process and describe how providers and patients will be impacted?
Yes, thank you so much for the question. Consultation is critical. IHS is a system that serves tribal communities, tribal nations, Native American people, and making sure that they have a voice in any realignment is essential for the success. It's challenging whenever federal agencies, particularly located in a headquarters office, hold that decision-making authority and don't understand or know the communities that are actually being served on the ground. And so that consultation process is critical to make sure that that input is received and that those voices are not only heard, but that part of the solution to put together a realignment plan. We definitely agree that there's opportunity for more effective IHS, a more efficient IHS, but we think that creating that realignment can only be successful if it's done hand in hand with tribal governments and with those that are receiving the care from the IHS.
Yeah. So as you know, some tribes report that area offices, when compared to headquarters, provide faster, clearer, and more accurate information. Are there any ways to improve area offices for 638 contracting needs rather than nationalizing or centralizing the process?
Yes, thank you for the question. There is a great deal of inconsistency across IHS's area offices. There are some area offices that are very high-performing and have very good relationships and are very effective in responding to tribal requests and moving forward with the negotiations in a very timely manner. There's others that are underperforming, and we hear tribes that have concerns about that. So we do propose that one IHS learn from the successes within those high-performing areas, see how it can duplicate it for the underperforming. In the meantime, while they're trying to make a national standard within the area offices for performance, that they could use things like a strike team and give that as a tribal choice or a tribal option, that the tribe can either work with their area office or choose to bring in the strike team that can also help build capacity within the underperforming area. We also think that the new Office of Area Negotiations is being created. Not all functions that are listed in there would be problematic. We think there's some really great things. The opportunity for more training, for more mentorship. We think that makes sense on a national level to ensure that agents and lead negotiators within the areas have the same capacity.
Yeah. Any of the other witnesses want to add anything? I have 26 whole seconds. Councilor Kachan, thank you.
Thank you for the question. I would say that the areas that have the least amount of self-governance tribes need the most help. And we've watched and witnessed the success of strong self-governance tribes, and organizations like the Self-Governance Communications Education, where Jay leads, is a mecca of information, and we need to support the work there and help. If IHS can't take it on, then we need to support the work where it's taken place. Thank you.
Thank you so much. And I yield back.
Gentlewoman yields. I want to thank the witnesses, each of you, for your valuable testimony today, and my fellow colleagues for your valuable questions. Members of this committee may have some additional questions for the witnesses, and we would ask that you respond to those in writing. Under Committee Rule 3, members of the committee must submit any of those questions to the committee clerk by 5 p.m. on Tuesday, December 16th, 2025. The hearing record will be held open for 10 business days for these responses. If there is no further business, without objection, the committee stands adjourned.